I'd like to welcome you all back. During the break, I was thinking about our last session, specifically how everyone talked about the importance of building and bettering systems that make optimal nutrition accessible, affordable, and with quality in mind. And while we're talking about systems, let's now delve into our next technical session, which is on AI, digital health, and innovation for youth well-being. The future is here, so it's time to seize it in order to secure success for our new generation. This next session will be chaired by Dr. Kirk Tickell, Assistant Research Professor, Department of Global Health, University of Washington, USA, who I welcome onto the stage. He, together with our distinguished panel, will help us explore how technology can be harnessed for adolescent health and well-being. I would also now like to invite our speakers. You know the drill by now, I hope, as I kindly ask you to make your way to the stage and take your seats as I call your name. Today we will hear from Dr. Mona Duggal, Director, Indian Council of Medical Research, National Institute for Research in Digital Health and Data Science. We'll hear from Dr. Pierre Thomas, Assistant Professor, Maastricht University, Netherlands. We will also hear from Professor Monica Arora, Vice President, Public Health Foundation of India. Dr. Shobha Suri, Senior Fellow, Observer Research Foundation. Let's hear some more enthusiasm, please. Last but not least, Dr. Tanu Gupta, Senior Program Officer, PATH India. As our panelists settle, my apologies. We have one more speaker as well, Ms. Kruti Dalal, Director, Resource Mobilization and Communications, Arman. As our panelists settle, a reminder that each speaker will have 12 minutes to present with a 10-minute reminder bell that will sound to indicate 2 minutes are remaining. Thank you again for helping us keep time. And now let's dive into the future. Dr. Tickell, over to you.
Okay, thank you, Rishika. So we've already heard a lot yesterday and today about the influence that technology is having on adolescents. We've heard that social media is challenging their identities and that it is leading to what was described as the anxious generation. Our keynote speaker this morning described adolescents as digitally hyper-connected but emotionally disconnected. And we've all seen this manifest in national newspapers through a mental health crisis that's leading to increased rates of suicide and other kind of tragic events. But at the same time, we all, I think, recognize the opportunity that technology provides. We've seen social media being used to mobilize political change. It was said, yesterday about Nepal, if Gen Z have been able to produce this kind of radical political change in 24 hours, why can't we use technology and social media to help Gen Z and adolescents improve their health within 24 hours as well? We are also living through an AI revolution. I'm sure everybody here has had a go on ChatGPT, whether it's to make funny photographs of our friends or to help write emails to our bosses. It is incredible. And there's such opportunity there, but equally risk as well. So I'm very excited today to hear more about how we can use AI, how we can use technology in the spaces that we work in and to achieve the kind of transformational health change that we all want. So I don't want to say too much, and I would now like to invite Dr. Mona Duggal to the stage. She is a director at ICMR's National Institute for Research in Digital Health and Data Science here in New Delhi. Mona.
Thank you. I will start from where we left in the last, and I will again be talking about why the data part is so important as we talk about digital health. So quickly, this is the outline that I will be talking about. I might skip in the interest of time because it would be good to have more time for discussion. I think we already are aware that there are 2 billion at this point who have micronutrient deficiencies based on the data we have. 1.9 billion, there's overweight or obese of this. And poor diet is responsible for more deaths globally than any other risk, including tobacco. And we all know the traditional dietary assessment methods that we are currently using, especially in the public sector settings, is burdensome as it and the self-report measures. It is subject to recall and portion size adjustment errors. It provides fragmented data, especially in low, middle, and income countries. Some of the things that I'll be opening up for the question is it really true? Because generally what we are seeing and where the policies are being made are generally the data that we are getting in the public system. But in the private sector, it is like really precision data that is already there, and maybe we are missing out on the big picture. So what are the national efforts that we have done? It is fortification and supplementation based on the current data, and who are the have they addressed this burden adequately, and who are the beneficiaries? We have subnational data on micronutrient biomarkers and dietary supplies to indicate an unequal distribution among different geographies. Again, the data problem. The Global Nutrition Report proposes nutrition data revolution, calling for quality data in policy decision making. It also proposes a nutritional data value chain from data collection to policy. I just skipped the NFHS away, I think, because our previous speaker did a wonderful job looking at the data that was available. But why it is important? We all know it is a critical growth and the development window, period of rapid physical, cognitive, hormonal, and psychological changes with high nutrient needs. This is the period where we are actually losing out. I think till 10, 11, I think a lot of parental supervision. But that is also the period when parents are actually pressurizing their children for higher studies and everything. And that is probably, I think we are missing out what is the mental health and the status which I think Suman had elaborated earlier. But I think it was something that we really need to now look at the holistic picture. It is high burden and persistent deficiencies. Micronutrients like iron, iodine, and vitamin A are commonly deficient. Vitamin D, of course, it is now persistent across, maybe including everybody out here. We are increasingly sitting in environments that are actually preventing us to go outside. Health is always an outcome of the well-being and of the urban planning. So maybe thinking around how we can have better areas where we can actually go out, sit around, and have the perfect environment for that. Another food for thought. Emerging double burden, double of undernutrition plus overnutrition that complicates public health interventions. So there was a recent ICMR study, people who have looked at the newspaper, children in the private sector versus the public sector. There was a clear divide. The children sitting in the public sector were actually much more healthier. The parameters were better. Children in the private sector, single child, going in an AC car, they had all the ingredients for a lifestyle disease risk factors. Again, a wake-up call for the parents. Long-term health education and human capital impacts. We are completely missing out on the working and the productive population that they are going to be entering. Opportunity for early intervention and habit formation. Where does it start? Should parents be involved? Is it the school? Is it the teachers? Who all are to be involved? I think as the previous Malaysia speaker did allude to that. We have to discuss that. What are the data gaps and need for scalable, precise monitoring? We have no data on youth nutrition, especially adolescents, which are limited or inconsistent. AI can help by enabling better dietary assessment, integrating multiple data sources, and scaling monitoring in low resource settings. So this is again, how do we get that data? Most of the adolescents are far ahead in the digital technology as compared to the population, like the people who are doing research. They are on the apps. They're already looking up their nutrition factors. They are, if you are obese, they are trying to get fit. Maybe there are nutrition labs that we need to cater. We need to reach out to them. We have other data like Zomato and other Swiggy. What are the food and nutrition patterns that they are eating? Are the parents working population? Should we get that data? So there are innumerable places where we now need to get the data, where we need to make the policies. So nutrition data is available at scale. However, it is often fragmented, non-comparable, and not integrated across systems, limiting its usefulness for real-time decision-making and policy design. Micronutrient assessments, large-scale surveys, and biomarker studies identify prevalence of key deficiencies. Again, are there already labs out there who are actually doing all these micronutrients? Do we need to reach out to the private labs for that data? And if they have, can they share it with the government for the policy decisions? Consumption and dietary data, household, dietary, diverse, food access, and affordability analysis. Again, it is majority of the rural and semi-urban. Again, we do not have the data. Behavioral and demographic analytics, surveys for recording patterns in nutrition outcomes by age, gender, location, and socioeconomic status. Monitoring and evaluation systems, real data platforms to track program coverage, uptake, and effectiveness. These are some of the government initiatives supporting data-driven nutrition. We are all aware of it. I will not get into it because I think the bigger picture needs more discussion. AI-driven nutrition strategies for youth. We have targeted nutrition policies which will have high policy impact. That is, and which we are looking at is personalized AI interventions which can enhance policy effectiveness nutrition. If we have low AI integration, but we are going by the traditional nutrition programs, it is going to be low policy impact, and we need, but for AI enhanced monitoring, we need improved data collection, but which lacks policy influence. So I think yesterday itself, I was actually talking to a few startups. Most of them are doing extremely well in the private sector. The biggest challenge for them to integrate in the public health system is there are no guidelines. So we have huge data in the public system that is generally related to rural and semi-urban, but we have very limited impact. Then we have a huge private sector where we have a lot of precision data, where that data is being actually bought and delivered for the startups, and they are actually using that data for precision nutrition. These are the nutrition area domains that we can see. The biggest is on dietary assessment. Next is lifestyle interventions. I one time actually asked a startup why you are not working in the public system. It said it's too complicated. We are only targeting the private sector. So this is again food for thought. Please think over it as we go forward. This is the overview of AI-assisted dietary assessment tools. What are the advantages? We all know they are user-friendly, time-efficient. The population that we are dealing with is extremely digital-friendly. They already know it. They were COVID population. They have actually been taught how to use the thing. So I think this is the right population if we have to do the digital interventions. Energy intake, macro and micronutrient estimations, captured, misreported, unreported data, captured snacking events, ALDS, MDDB, score estimation, carbohydrate counting. I don't know, like many people who go outside, I've seen many people taking photographs of what they eat. So I think that awareness is already there. If you actually just go around, I think looking at the behavior of most of the adolescents, this can be actually brought in to get the data. Maybe crowdsourcing might be a method. Objective passive data collection, there's a low participant burden, bite counting for energy intake estimation, eating behaviors, captured snacking events, food environment, social context, food purchase behavior, activities during eating, for example, screen use. I think there are more questions than answers, but just looking around will probably give you a lot of answers. Just going to a grocery store, see how the people, what is the kind of foods they eat, what is a simple groceries setting and how people take the food. There are simple interventions, but just observing and getting the data would be quite helpful. Challenges are there: energy overestimation, underestimation in some areas, low accuracy in portion size estimation, and reduced accuracy in video-based data collection. Low accuracy, so we might have second challenges: capturing of inappropriate images. There are privacy concerns, discomfort while wearing some of the devices which we are now asking, many of the IoT devices, under and overestimation of energy intake, and camera and device malfunction. This is a nutritional data value chain in response to the data problem. We need to prioritize key indicators, identify essential metrics for nutrition assessment, collect high quality data, even less. I think it is fine, but we have to have the right and the correct data across, curate for interoperability, ensure data systems can effectively communicate, analyze gaps, trends, and interpret and act. What is the determinants of AI-driven nutrition? We have healthcare professionals that need to work with the data science and AI. They have a nutrition science, industry and technology, and policy and regulation. So input is health data, omics data, behavioral data. Output is predictive models and recommendations. For healthcare professionals, we need clinical guidelines and patient profiles. Output is validated and usable AI models. We need input for nutrient biomarkers, microbiome, gene-diet interactions, personalized dietary plans. And the input and the industry and technology, technological implementation platforms, consumer-facing solutions, and real-time systems. These are the real-world challenges, nutritional data research. Where we have data utilization, it is underdiagnosis, and in data integration, there is a delayed policy integration. Due to poor program design, by the time data comes to the policy, it is already the next cycle. So I think we really need a real-time tracker where you can get the data and you have real-time tracking and immediate policy evidence. We have, for the first time, I have seen it myself in my research career. I worked in the fortification. We had the National Fortification Policy. Started in 15 and 16. In 2017, we had the National Fortification Policy. Recently, we have seen the obesity. So I think we are improving, but there's much more to be done. These are something I'll just be skipping because, again, we have, I'm sure next speakers are going to be talking about. I'll come to where we are actually looking at. Policy with empirical evidence, translating data insights into nutritional policies. We have 3 case studies that we'll do. Why it is important. First is the data-driven integration for great impact in the PDS. This has been implemented where we have looked at data-driven learning has enabled a continuous refinement under the national food security policies and delivery mechanisms, which is based on real-time data, local feedback, and interstate lessons. So this has actually improved the delivery of many of the PDS systems, where how the food is being delivered, where there is inefficiency and better quality food is being delivered. So using audit data and community feedback to map the delivery gaps, tracking exclusion errors, inactive cards, and missing beneficiaries is important. Enabling real-time data correction of ration cards, and during audits, increase the coverage from 78% to 84%. Data from audited blocks showed strong results, 99% satisfaction with grain quality and 61% increase in ICDS access. This was done as Orissa in public distribution system and other welfare schemes. Second is where I was personally involved as a Haryana demonstration project on wheat flour fortification and effect of quintuply fortified salt on micronutrient status of non-pregnant women of reproductive age in Punjab in India. This was one of the key studies. It was a well-designed study where advocacy, science, and the implementation research was at the fore. The impact was such, people who got trained they were actually leading the FSSAI. So you can see there was a capacity building. The data was so well received. We had a high impact outputs that it actually impacted the fortification policy. So Haryana actually took up the fortification policy. We started from 1 district and it was scaled to 5 districts. And eventually it was one of the evidence that was created at the national levels. Outcomes, it was high quality databases, publications in high impact journals, evidence creation and policy implications. Last is nutrition research and policy change. This is what we are now proposing, having surveillance units or federated structures at the state units to have the market survey data and the local data and the other data that can be converged at the state levels as computational health units so that they can be real-time tracking. Health is a complicated subject. It is a federated model. It is a state subject, so you have to take the states together. We can give guidelines, but at the state level, you will have to build the capacity. So this is capacity building, evaluation, advanced analytics, and policy directions. In the interest of time, I'm just putting up the slide for your review. This is what we have proposed, where you have the FSSA advisory along with the ICMR, where you have NIN and our institute working together to get the data together. We have the key top 4 institutes at the national level that we are working together at St. John's, PGI, NIN, and in Uttar Pradesh, and the development partners like GAIN, NIFTIM, where we are all working together to get this working. Working with FSSAI so that whatever we are doing gets back into the policy and the MOHFW level. So this is what, again, strengthening India's nutritional data ecosystem. I'm again putting it up for review. I will not be going into everything. And these are the future directions: having personalized nutrition, disease management, and policy implications. Future success requires addressing data quality, bias, privacy concerns, and digital divide to ensure equitable access to nutrition technology. So, this is, I think if everybody is aware, there's a One Health mission that is going on. And this is again an attempt to get all the ministries together to ensure that we get data from various resources. So with that, I end my slide. Thank you.
Thank you, Dr. Diggle. You've really outlined the importance of data-driven policy design. And I think just given us a nice flavor of the tension between the private sector and the public sector, the advances that the private sector is making and the difficulty that they're having integrating with the public sector. And I think, your case studies are so motivating to see this going beyond a theoretical discussion of what AI and technology can do for us and beginning to see some results on the ground. That's fantastic. I'd now like to call to the podium Dr. Pierre Thomas, who is an assistant professor at the Institute for Public Health Genomics at Maastricht University in the Netherlands.
All right. Thank you very much. I don't need a box. I'm tall enough. So again, welcome everyone. I would now like to talk to you guys a little bit more about the use of AI in reproductive health for resource-limited settings. I'd like to give you guys some overview of what has been working really well, as well as some of the challenges. As introduced by Dr. Kirk, I am from the Institute of Public Health Genomics at Maastricht University. There we focus on translational research, meaning that we try to take the best knowledge and the best technology that comes from universities and research centers, and we try to make it more accessible, and we try to translate it on the ground for those who need it most. We're very fortunate to partner with Sukaria on this, but also with Mahe in India. In Kenya, we work together with Kemri on point-of-care diagnostics. And in the Kingdom of Saudi Arabia, we work with Jazan University and the local authority on how to promote HPV vaccination in a cultural sensitive way. Right, moving on, I'd like to go over some of the key opportunities for AI. I'm quite excited to tell you guys more about it because I will actually go through a lot of the points that were mentioned yesterday through the lens of AI, so it'll also serve as a bit of a refresher. Right, talking about the field of maternal and neonatal health. When we look at predictive analysis and early detection, AI models have shown great success at predicting complications such as preeclampsia, gestational diabetes, and postpartum hemorrhage. And in fact, this has been done with machine learning algorithms such as naive Bayes and SVMs. When we look at wearable sensors, that was also mentioned in the previous presentations, equipping expecting mothers with wearables and sensors can help monitor in real time the maternal and the fetal vitals. This thereby reduces the needs for in-person visits and helps to improve the outcomes, especially in rural areas. We also have very interesting and compelling AI tools in the field of ultrasound and diagnostics. One example that is particularly prominent that I would like to talk to you guys about is the Baby Checker by a company called Delft Imaging. This allows non-experts, as you can see, equipped with this nifty little machine and the smartphone to conduct ultrasounds and detect risks, and that thing works offline as well. It has reached as far as 97% accuracy in fetal head circumference, thanks in part to the AI algorithm it uses. When we look at the access to sexual and reproductive health services, have you guys met Snehai? It's basically talking about how chatbots and virtual assistants can provide 24/7 sexual and reproductive health education, can help you check your symptoms, it can facilitate triage, and all of this is available in local languages. So Snehai featured over there is a compelling experiment coming from India, where she will offer you non-judgmental sexual and reproductive health advice via Facebook Messenger, doing so with storytelling and game approaches. There's also really interesting data coming from Flow, which is a very successful period tracking app. Their Pass It On project has been providing sexual and reproductive health education to upwards of 20 million women in low and middle income settings, also contributing to reducing stigma as well as improving literacy. When we look at telemedicine, at the opportunities for telemedicine and mHealth apps, these can actually help bridge the gap between rural and urban areas by offering remote consultations and reminders. And here we have a very compelling examples coming from Kenya through the Prompts app that uses SMS and AI, so a rather low-tech approach, very less resource intensive, which is helping mothers follow up, which is helping mothers make meetings for their expecting or born children, and this has tremendously helped improve healthcare uptake. AI can also help us combat sexually transmittable infections and help us screen for cancer. It can be used in AI and radio. It can be used in radiotherapy and imaging, where tools like the Radiation Planning Assistant, the RPA, can improve access to radiotherapy in low and middle income settings, which is now reaching 93% of usability for cervical cancer cases. Other apps facilitate the diagnosis of sexually transmittable infections, such as the AI platform eHealth, which can analyze visual symptoms and questionnaires to diagnose STIs with a 94% accuracy, offering confidential remote care. We also have very interesting risk prediction tools such as the My STI Risk app from Australia, which calculates an individualized STI and HIV risk using self-reported data, and which encourages testing and early intervention. Here again, an overview of all of these compelling initiatives across the world. But as was already hinted at by the previous speaker, I think it is also very important for us to also pay attention to the ethical concerns as well as to the challenges. Of course, when we talk about sexual and reproductive health data security and privacy are paramount. And it is in fact a very important aspect to consider who has access to the extremely sensible data that patients may be inputting into the AI models. And currently, both in the West and in the global South, we have weak or emerging regulatory landscapes which are not fully able to protect individuals yet. Solutions to that could be an uptake of anonymized data, uptake of blockchain technologies, and adherence to the WHO ethical guidelines, where awareness and digital literacy play a crucial role. We can also think about potential biases and inequities in the field of AI, and especially when the AI models come from high-income settings and are trained on data sets from high-income settings, which may not reflect the context in low and middle-income settings, which could also lead to misdiagnosis and exclusion. The solutions to that are diverse data sets and participatory design with the local communities, continuous audits, and I'll mention it a couple of times, but I think it is central to the AI question to keep in mind. Every time we use AI, we must maintain a critical spirit. Further ethical challenges. In terms of transparency and accountability, the risk is that AI is a black box, so we are not always sure what all goes on in there and what goes into the manufacture of the messages and output of the AI models. This can undermine the trust and the liability that is put in these models. Therefore, potential solutions are explainable AI models, embedded accountability mechanisms, and again, clear and effective regulatory frameworks. We can also think about the importance of informed consent and autonomy. It's important to remember that the end users of AI models might not understand how AI actually processes the data or influence their decision making. So that's where we need simplified explanations, a lot of human oversight, as well as ethical review boards. From a personal request from Miraji herself, I was asked to come up with some digestible and clear pointers for especially for the NGO stakeholders, and I've listed them on the slides for your review. It's important to start advocating for ethical AI and to push for policies that align with the WHO principles, to campaign for ensuring transparency, equity, and accountability surrounding the use of AI. We need also to support local adaptations through collaborative AI tools that are tailored to the unique landscapes of low and middle income settings, including cultural, linguistic, as well as infrastructural needs. We also need to invest in digital literacy. That includes training healthcare workers and communities to use AI effectively and safely. Again, critical spirit is kind of the leitmotif here. We can also prioritize data privacy by demanding robust protection laws and anonymization practices in AI-driven sexual and reproductive health program. And finally, something that I found really interesting when researching for this presentation is that, including in settings like in India, there's still gender divides in the access to technology. In fact, even in rural areas, it has been reported that upwards of 70% of men have access to a smartphone versus 35% for the ladies. So this is something where NGO partners such as Sukaria must ensure that AI tools actually empower women and girls and that biases in development and design are addressed from the development perspective. That was it for me. Thank you very much for your attention. I would also like to thank Nora Wisman, whose thesis work has inspired this presentation. In the meantime, I wish you a very nice day, and I'll welcome your questions after the session. Thank you very much.
Dr. Thomas, that was fantastic. That was a very, I think, balanced overview of the potential benefits and current applications of AI versus some of the ethical concerns. And you've reminded me of a very sad case in the UK related to the transparency of AI. A young adolescent boy there befriended an online AI, and it essentially became the primary person that he was talking to in his life, and began to express suicidal ideation to the AI. And while the online platform did try and validate what he was feeling and say that it was normal that he felt that way, it offered no help and did not refer him or tell him that he needed help, to the point that he began to plan a suicide attempt, which he went through with and took his own life. And only subsequently did his parents find this chat history. They've moved forwards with suing that platform, and the producers have said, well, we programmed it to tell somebody or to reach for help or to encourage him to get for help. But in this situation, it didn't behave in the way that it was meant to and the way that it had been programmed, which I think just illustrates the unpredictability of artificial intelligence, and that this is having a real world cost already. It's not a theoretical conversation. Next, I would like to welcome to the stage Professor Monica Arora. She's Vice President of Research and Health Promotion at the Public Health Foundation of India in Gurugram.
Good afternoon, and thank you very much, Sukarya, for giving me an opportunity to present a continuation of what you would have heard in the earlier session from Preetu about Let's Fix Our Food project, which is a consortium activity in India. And as we have also heard since morning, I've been hearing the terms like co-creation and well-being of adolescents, engaging adolescents. This particular session focusing on AI, digital health, and adolescent well-being is ideal to bring all of these concepts that we have been talking about since morning into real practice. So what I am going to talk about is how adolescents are surely not only actors of social media, but also prominent consumers. So when we talk about digital health, they are the ones that it should speak to. Also, the topic that I am going to touch upon is how this whole intervention and the conundrum of solutions that we are talking about is so multi-sectoral. It's not just the Ministry of Health that we need to talk to when we have to address anything to do with nutrition. And it is not just multi-sectoral from the point of view of government's responsibility, but each and every one of us being responsible for every solution we talk about today. So Let's Fix Our Food brings together that perspective of fixing nutrition not as a multi-sectoral issue, but also a whole of society and a multi-stakeholder initiative. So we have heard about the problem again since yesterday about triple burden of malnutrition in India. But what I'm going to talk about and Let's Fix Our Food was launched when nobody was wanting to talk about overweight, obesity as a problem in India. It was only undernutrition, which was the mainstay. The Poshan Abhiyan only talked about addressing malnutrition as undernutrition. At which point, thankfully, Niti Aayog did take cognizance of some of the research Public Health Foundation of India had undertaken about the aggressive advertising environment in which children and adolescents were growing. We presented the research where we did content analysis of advertising exposure in children channels and youth channels. And these were television channels at that time. 80% of the advertisements were of food which were high in fat, salt, and sugar. And this exposure was much higher in children channels as compared to youth channels. So which was very clear, the manufacturers want to target them young so that they have lifelong consumer of their products. So these findings definitely underscored the problem, and a multi-sectoral and a multi-stakeholder engagement consortium was put together by Niti Aayog, identifying areas that we need to work on, not only from the perspective of overweight, obesity, but see overall nutrition environment for children and adolescents. And we looked at complexity and whatever were the determinants of nutrition, and what we used to talk about social determinants of health are now commercial determinants of health. And a lot of literature in India and South Asia has been produced by us in this regard as to how these commercial determinants are influencing the food environment. We did look at various stakeholders that need to be brought together. So major players in nutrition in the country are active contributors to Let's Fix Our Food. We did bring in civil society, youth engagement, peace, and health in all policy approach was adopted. But when we were saying that, okay, there is civil society, there are researchers, there are other stakeholders, one missing piece was adolescents themselves, who were missing from this entire matrix. And that's where we brought in the youth, which is the meaningful engagement of adolescents and youth, which is not to have a tick in the box that they come to one of the meetings and give contribution, but they should be the ones who are going to change their food environment. Because time and again in public health policies, very clearly we have seen a top-down approach of government bringing in a policy never translates to its implementation till the time there is ownership from the target audience and the community about it. So that's where we wanted to work on top-down as well as a bottoms-up approach. So top-down, there is a national multi-sectoral action plan for NCD prevention and control, which has various ministries, and there are various programs which are nutrition-specific interventions, even in the school setting. So Ministry of Education is an important player, Ministry of Food Processing Industry, Women and Child Development, Ministry of Health, definitely. So we did look at all the existing programs, interventions, and policies and identified where the gaps were if so many ministries had a mandate of fixing the food environment. And with that, we launched this initiative. We identified a few areas as priority areas. So double duty action. We did research on putting all the data together. Front of pack labeling became a very important advocacy issue because many other organizations were working in that regard. Nutrition literacy approach, which was led by adolescents themselves. Taxation of HFSS foods and regulating advertising, which was the main evidence with which the initiative started. So this is the entire ecosystem of Let's Fix Our Food with a long-term vision to transform attitudes and behaviors of adolescents across context to be able to fix the food environment, and they themselves being the promoter and implementer of ensuring healthy food in schools, communities, and families as well, because actually the food comes from the home. So if we are not able to influence the family food environment, all the teachings in the schools are not translating into sustainable behavior change. So youth were sensitized, trained to become health ambassadors for LFOF, and they started social media campaigns. They started talking to peer groups, they became peer leaders, they started talking to experts, they did podcasts, they analyzed their food environment in schools, what was going wrong, what was not as per the existing policies, and they tried to take those to their school management, to the communities, and started taking action on ensuring there was healthy canteen policy, there was healthy food which is available at home, there were programs in schools which are on healthy nutrition. So they did policy level action, youth-led health promotion in IEC campaigns, created resources, conducted workshops, but also capacity building and resources which came from scientific publications of Let's Fix Our Food. So we as researchers did the research bit. We conducted a U-report through a survey which reached about 143,000 adolescents in the entire country, and each and every state and union territory did participate. And some data points very clearly highlighted their food choices were dependent on affordability, were dependent on what they see on advertisements and what was easily accessible. So very clearly highlighting that policy needs to be fixed when they need to eat healthily. So first scientific publication which came out was on advertising policies, and we looked at all the advertising policies in India under different ministries, and a robust regulatory framework was identified as the need of the hour to protect children from foods which are being marketed as foods high in fat, salt, and sugar. So we looked at that the recently introduced guidelines for prevention of misleading advertisements and endorsements for misleading promotions is the most promising policy, but that needs some of the clarity on what is junk food. We need a clear definition, what is the children-specific channels meaning in these policies. So those gaps were identified and advocated for change. Similarly, we did a scoping review on how SBCC campaigns can be promoted and presented. What is the level of taxation required? We started with sugar-sweetened beverages, and we know with the current taxation, we have not made a dent, but we need to increase the taxation further to hit demand. The impact of Let's Fix Our Food this was presented, and actually the outcomes were disseminated by the Niti Aayog, which is our planning commission, and the DGICMR. So the highest level of ownership and commitment we could get from government was sought by these adolescents from the decision makers. And we were, as a consortium, tasked to write a national nutrition strategy for adopting a life course approach. And this document is currently under review by various ministries and by experts at Niti Aayog. Also, schools have now started becoming Let's Fix Our Food schools. State governments are approaching us on the methodology so that they can adopt similar campaigns at the school level. And youth continue to take these evidence and outcomes in ensuring that various state governments as well as their schools are able to follow the guidelines which are the mandate in various programs. So in summary, we need to fix the environment which is supportive and enabling for youth to be able to adopt healthy food. And with that, individual level action is surely required, but family and community norms too have to be changed. And at the government level, policies have to make evaluations and impact to be able to have healthy future and healthy food environment for our children and adolescents. Thank you.
Thank you so much, Prof. Aurora. That was fantastic. I think the keynote this morning laid down a challenge to see how can we harness adolescents and their creativity and their voice and use that to change adolescent health. And I think you've shown us through your work how you've done that, how you've used the adolescents' voices in the design of your program and then used it again as advocates for change. So I think that's really fantastic and just really wonderful to see how your work has been opposing those commercial drivers of poor nutrition that you met. So thank you so much. Next, I would like to call to the stage Dr. Shobha Suri, who's a senior fellow at the Health Initiative and an observer at the Research Foundation, New Delhi.
Good afternoon, and thank you to Sukarya and Meera ma'am for inviting me to speak among such esteemed panelists. It's very difficult. Okay. I thought I was tall. So, yeah. Thank you, ma'am, for inviting me to speak among such esteemed panelists. It's also very difficult to talk among, after all the speakers have spoken and some of the points which I had to raise. But yeah, nevertheless, this is something we've been talking about since yesterday. And today, again, we talked about how AI could impact, artificial intelligence could impact, actually impact how some of the tackling of some of the adolescent obesity, overweight, as well as the undernutrition or thinness, which we call. So there are tools which are available, and how those tools could be scalable and could be used. This comes from some research which I had done, and I also learned a lot during putting this together, and also comes from some of my practical tips which I got from my adolescent daughter. So being a mother, so I got some practical tips from her too. So yes, adolescents, we have been talking about how it's a paradox between double burden of malnutrition, rather triple burden when we are talking about anemia. It's undernutrition on one side, and the growing concern of obesity due to all the ultra processed foods consumption which is happening. So I'll take you through some of the data which has already been talked about, but just to reiterate, these are some numbers which we have been seeing since yesterday, how there has been a rise in the trend, not only in undernutrition, but rather the obesity and the overweight levels are increasing over the years. And something which is worthy to note is like 1 in 20, when we talk about 1 in 20 children under 5 are living with overweight, but it's 4 times the number when it comes to adolescents. It's almost 1 in 5 living with overweight. Obesity is also growing concern, and there's a lot of share of obesity which is undergoing in terms of the overweight cases. Just to give you an example of a trend, over the last 2 decades, this trend of obesity has increased from almost 30% to 42% right now. So it's a cause of concern. Some more numbers. Some of the previous speakers had already spoken about this, how there's been an historic turn in the prevalence of underweight being, the overweight being more than the underweight, with 9.4% of overweight and compared to the 9.2% of underweight. There has also been this crossover, the point at which the prevalence of overweight is going the underweight no longer going to be exceeding the overweight. It's projected by 2028, in terms of adolescents between 15 to 19 years, it's going to exceed. And in terms of adolescent age between 10 to 14 years, it's going to be by 2029. So this has got a very big economic impact. When we look at how this overweight and obesity numbers are going to actually impact almost $4.32 trillion annually to the economy. It's almost similar to the 3% of the global GDP, which we saw at the time of COVID. It's something comparable to that. Why focus on adolescents? Everybody has talked about it, but just it's a critical development window where there's rapid growth happening, where there's hormonal changes happening, and they have an increased autonomy on what they want to eat, the food choices they want to make. And this also has long-term consequences. Like if you look at undernutrition, almost 15 to 20% there is a school dropout, rate in the school performance. If you look at obesity, it's almost increasing by 50% of the type 2 diabetes, and also long-term consequences in terms of the non-communicable diseases. We do have traditional interventions, but it reaches only to 20 to 30% of the at-risk youth. And we've also heard from some of the previous speakers how traditional methods are not able to bring about that kind of an impact which it should. So where do we come from? We're talking about some smart nutrition, which is like how AI can empower and help bring about some scalable tools which could help the adolescents and the young population at risk to overcome the impact of the overweight and obesity. There are some tools which are available. Some of the previous speakers have also talked about it. Something called the predictive screening. This can detect nutritional risk up to 6 months in advance with an accuracy of nearly 85%. Then we have personalized diet apps, which help with image recognition and intelligent meal planning to achieve up to almost 90% accuracy in terms of the calorie intake. Then we do have wearable integrations of wearable apps, which were talked about by my previous speakers, which not only track the nutrient intake, but also the physical activity, which is very much essential when we are looking at the long-term consequences of non-communicable diseases in the future population. At some point of time, most of us would have used some of these apps or maybe using. They are useful to an extent, but there are challenges which are also there. The technologies which are used are basically machine learning, the natural language processing, or even the CNNS, which when the previous speaker talked about how this, we take the picture of the food, this is basically an app which is used for the video and the image analysis. And also we have generative AI, the AI chatbots, the chat GPT, which we use for various purposes in our day-to-day activity. The UNESCO data says that there is 70% of adolescents owning smartphones. So that means this kind of a tool can be scalable and can be implemented if there is enough awareness and enough training of how to use it logically. I don't want to go into details, but yes, there are some of these studies which have shown that some of these machine learning and some of these apps have actually shown accuracy of about 85% in studies done in Ethiopia and in Bangladesh. And there are some of these apps which actually are predicting adolescent obesity much in advance, something like the Deep Health Net or the Stanford Research Institute's nationwide study on adolescent obesity. They are screening, they are not only screening or forecasting obesity risks, but they also guide on the preventive measures, which is all the more important. Instead of, looking at it once the damage has happened, it's better to prevent it at an earlier stage. And collectively, the impact has been quite high. The prediction accuracy has been almost between 70 to 90%. And it is also helping in overcome it's more improved over the traditional methods. And also helps in, developing more targeted and individualized interventions. Looking at some of the personalized nutrition apps, we have the photo analysis for calorie estimations. Then we also have some culturally relevant suggestions of how one can, use millets over rice in terms of how the iron intake can be improved. There is a lot of gamified platforms which have come up now, which the youth are using for healthier choices. Now they look at what they should drink, like, should a zero Coke be taken, or should a normal Coke be had, or should we have something equivalent which has less sugar? So, and talking about some of these, previous speaker spoke about some SNE AI. There are apps like those Healthify, which they have chatbots in terms of called RIA. It gives you a kind of a personalized overview of what should be consumed, what should be the physical activity based on your various data on your height and weight and the BMI score and everything. So, and there are benefits of using such personalized nutrition apps. Firstly, they not only improve the dietary assessment with precision and scalability, they also have culturally appropriate interventions. But at the same time, these strategies are also effective in building a nutritional knowledge and habit, bringing about a positive change in the behavior. Some of the speakers have already spoken about some of these wearable apps, like, we sync with Fitbit and Apple, and there are much more available these days in which the predictive analysis can help you with preventing kind of the weight cycling or the yo-yo diet, which is like, sudden increase in weight and sudden decrease in weight due to some crash dieting. So this predictive analysis can help in monitoring the body system. And also generative AI, which can craft recipes based on your eating habits. Studies have shown that these are scalable, and these offline, they can also be used offline where there is low connectivity areas. These are some real-world impacts, some case studies which have shown that such digital apps and interventions can reduce the BMI or the Z score in adolescents. Yes, the data which they have, it's a mixed data. Like, we have discussing about what kind of a cutoff should be used, but this is a multiple set of data which has been, fed into the programming. So that's why it gives a kind of a standard kind of a BMI or a Z score. Not all of them are cost effective, but yes, some of them have shown that these are very return on investments are quite high. They range between around 10 to 15% to almost 45% of the cost return. But yes, challenges are there. There are dropout issues in terms of when we especially talk about gamification apps, where there's gamification fatigue. We also feel bored after 3 to 6 months. We don't want to use the app. So then there is a potential dropout. Challenges, as mentioned earlier, yes, data privacy challenge is always there. And it's been seen that only 20% of these apps are GDPR compliant. GDPR is the General Data Protection Regulation. So that's a cause of concern. There could be algorithmic biases, which is basically a computer generated error, which could, and also sometimes it's like, some of the non-Western cuisines are underrepresented, leading to poorer accuracy. You might put a picture, but the photo analysis would not be able to detect what that recipe is, so it might give a wrong data. Access gaps, yes, definitely. The lack of internet for this 1.3 billion is including children between the age of 10 to 19. So this also includes children and adolescents. They lack internet, and as I said earlier, the gamification fatigue, the drop-off rate could be high. Yes, the future, the scaling of impact, I mean, it's important, but when we look at these innovation, there are federated learning, which are bias-free models in which the data privacy is maintained. Then we have the virtual reality, where there could be habit building, or the blockchain, which are like the digital ledgers, where your data privacy and data security is concerned. Then definitely these offline apps will be very helpful in low connectivity regions. And also, as based on the Lancet, I mean, there is a potential to prevent about 50 million or 5 crore cases of obesity by 2030. So I think what needs to be done is a call to action, wherein we need to integrate these AI into schools, clinics, and homes, so that it is uniform across the various regions and the diverse population. Lastly, to conclude, yes, AI can transform adolescent nutrition with precision and scale. It's got a proven impact of almost 85 to 92% in terms of detection, and also 10 to 45% when it comes to behavioral shifts. The equation is simple. Investing in smart nutrition is investing in thriving generation, or like the speaker yesterday said, we are the change makers, the future generation. So what we need to do is deploy, refine, and scale some of these AI tools globally, so that they can be used and they could be more impactful. Thank you so much.
Dr. Suri, thank you so much. You've really kind of taken us to the next level of saying, what is actually out there right now, and in your case studies, kind of what are the pros and cons, and even the cost effectiveness, and how would that actually work in terms of data security in the Indian setting. So that was very, very helpful. Thank you. Next, I would like to call to the stage Ms. Kirti Dalal, who is Director of Resource Mobilization and Communication at RMAP.
Thank you. It is a great privilege to be standing up here today. There is so much to learn and absorb from these technical sessions, and also the conversations on the sidelines. And I'm very grateful to Sukarya for creating such an incredible platform for learning, knowledge sharing, and for inviting us to be a part of it. I'm going to be taking many steps back to a time that plays a foundational role in adolescent health. I'm here to talk about Arman's tech-enabled scalable solutions for maternal and child health, and I will take you through our approach along with some specific solutions. But first, let me start with the story of Anita. Anita, a 23-year-old living in Dharavi slums of Mumbai, was pregnant with her first child. In the 3rd month of her pregnancy, she visited the antenatal clinic at Sion Hospital. Over 4 hours of waiting in the sweaty, hot, dingy, overcrowded clinic, only to get 1 minute with an overworked resident doctor meant she never came back again, except when she was rushed to the emergency room in her 9th month for delivery. She bled to death during labor. She did not die due to a terminal condition. She died due to underlying anemia, an easily preventable, treatable condition. Anita is one of the thousands of women who still die while giving birth in India every year. We know the statistics. We've been listening to them all day. We also know that the problem extends beyond birth. 1 out of 3 children are malnourished, preventing them from realizing their full potential as adults. Had the doctor counseled Anita well, would she and her child have survived? Had she had necessary information, would she have been more alert to danger signs? Had Anita's health worker been trained to manage and refer high-risk conditions in time, would she have received the necessary care? Imagine the impact this case had on the harrowed medical resident who would then go on to witness many such cases of preventable death and morbidity. What did she do? In 2008, that resident, Dr. Aparna Hegde, whose shoes I'm filling today, created Arman, an NGO that addresses systemic problems affecting maternal and child health by leveraging technology and existing health infrastructure to create scalable, cost-effective, and evidence-based solutions. We call this the Tech plus Touch model. We provide critical preventive care information to women during pregnancy and infancy, along with training and supporting health workers at all levels of the system. We believe that an informed and empowered woman will adopt better health behaviors and will proactively anticipate problems, decipher danger signs, and seek timely care. Adequately skilled, trained, and empowered frontline health workers will provide support and reinforce the woman's quest for care. They will diagnose high-risk factors in time to ensure early referral to higher care before it is too late. This, in turn, will reduce the load on bigger hospitals and free up their bandwidth and improve the functioning of the health systems, thereby leading to lower maternal and child mortality and morbidity. Let's take a quick look at the interventions for women and children. In collaboration with the Health Ministry of India, we implement Kilkari. This is a free national mobile health service focused on preventive care that delivers weekly, pre-recorded, but stage-specific audio messages to pregnant women and mothers with children under the age of 1. This is across 27 states in India, making it the largest maternal messaging program in the world. In Mumbai, we have a similar free voice call and messaging service for pregnant women and mothers with a focus on high-risk pregnancies and improving data in partnership with the municipal corporation, the BMC. We have Swasth Kadam, which is addressing the biggest high risk among children under the age of 5, which is malnutrition. We intervene early over here by providing live telephonic counseling and handholding to caregivers of moderately underweight children to prevent their decline to more severe forms of malnutrition. On the health worker side, we have Mobile Academy. This is the complementary program to Kilkari, which is also implemented in partnership with the Health Ministry. This is a mobile-based refresher training for frontline health workers, which has trained almost 450,000 or 5.4 lakh ASHAs in 17 states. Again, it uses a simple interactive voice response, better known as IVR-based technology, which makes it accessible even to those with a simple handset. The Integrated High-Risk Pregnancy Tracking and Management Program trains and supports health workers at all levels of the health system, including nurses, doctors, and specialists for early detection, management, and referral of high-risk cases. In tribal and rural areas that are severely underserved, such as Nandurbar and Palghar in Maharashtra, where we also see a high proportion of adolescent mothers, we train the ASHAs to provide home-based care to these women. This use of technology has afforded us massive reach. Through these interventions, we have reached 70 million women and their children in India till date. We reach over 14 million or 1.4 crore women every year through Kilkari, which is almost half of the estimated number of annual pregnancies in the country. And these interventions work. An RCT conducted by Johns Hopkins estimated that almost 14,000 lives were saved over 4 years due to Kilkari. Our ongoing endline in Swasth Kadam shows that 34% of moderately underweight children in the program moved to the healthy category. A study of auxiliary nurse midwives, or ANMs, in Telangana indicated a 17% improvement in their knowledge and skills post-trainings on high-risk pregnancy protocols. As we enter the next phase of our growth, we are moving from a one-size-fits-all to a more fit-for-purpose approach. What that means is that low-risk women and children will have access to nuanced voice calls and or multimedia content with two-way communication using WhatsApp based on their access to technology. Those with high-risk conditions or encumbered by equity issues will be supported via additional targeted content, including multimedia approaches, two-way communication, and long-term handholding via call center and WhatsApp. We are also piloting lateral approaches with peer NGOs among some of the most vulnerable communities, such as religious minorities, scheduled castes and tribes, migrants, to ensure that no one is left behind. At Arman, we are building a continuous innovation process that is human-centered, data-driven, iterative, and evidence-based. Let's take a look at how we're using technology and AI to enhance our solutions. To better serve our diverse Kilkari subscribers with differential access to technology and varying health needs and social locations, we have introduced the option of receiving the messages on WhatsApp. This allows asynchronous information sharing, richer multimedia content, including videos, digital posters, audio, quizzes, and interactive nudges, as well as technology-enabled two-way communication. We've already launched the pilot in 4 states, and Kilkari is now available on both IVR and WhatsApp in UP, Chhattisgarh, Assam, and Odisha, where we have more than 200,000 or 2 lakh active subscribers on WhatsApp. We're also using technology to better serve those with high-risk conditions, so more targeted approach. Earlier this year, we conducted a WhatsApp-based high-risk pregnancy pilot in Vasai-Virar region of Mumbai, aimed at supporting anemic pregnant women with targeted information along with hand-holding support. After 8 weeks, almost 80% of the anemic women had shown an increase in their hemoglobin levels, with 6% completely reversing their condition. We're now integrating this in the Mamitra program we are implementing in collaboration with the BMC, and we're going to build a similar WhatsApp product for women with other high-risk conditions, such as gestational diabetes and hypertension. A key challenge in health information delivery programs like ours is that a significant fraction of subscribers will drop out of the program, a point that was just highlighted by Dr. Suri 10 minutes ago. Non-profits like ours have limited health worker resources to place crucial service calls for live interaction to prevent such engagement drops. Hence, we collaborated with Google Research to build an AI model to predict which subscribers are most likely to drop out of the system, and then used targeted interventions such as SMS nudges and live calls by our call center staff. The AI model was able to reduce the engagement drops by over 30%, and the women who had the lowest listenership patterns benefited the most. In collaboration with ArtPark, we have built a multilingual, multimodal WhatsApp chatbot for the ANMs or the nurses. It responds to their text and voice queries on high-risk pregnancies and antenatal care, enabling real-time, personalized handholding and reducing the burden on medical officers who only then answer the queries that the chatbot cannot answer satisfactorily. The LLM or large language model-based chatbot is now available in 2 states, UP and Telangana, with over 1,000 users. 650 users have used the chatbot at least once, and we have received over 11,000 queries in just the last 6 months. We are now piloting a similar chatbot for pregnant women and mothers in Mumbai. Our use of the Tech plus Touch model allows us to achieve scale cost effectively without duplicating efforts. Since we partner with national and state governments and leverage their health worker networks without creating any parallel infrastructure, we can achieve non-linear growth at extremely low cost. For example, it only costs 25 cents or 19 rupees to support a woman through pregnancy and infancy with Kilkari calls. And this Tech Plus Touch model is what will enable us to meet our audacious goal of reaching 100 million women and their children and training 1 million health workers across all the cadres by 2030, while ensuring the programmatic depth and multiple touch points were required. Thank you.
And thank you so much, Mr. Lal. That was fascinating and such a powerful example of how mHealth can achieve scalability so quickly and with such reach. And then once you've got that, you can use it as a platform to innovate on and really drive change. Really fantastic. Thank you. The final speaker for our session today is Dr. Tanu Gupta, Senior Program Officer at Digital Health at PATH India.
Hi, good afternoon, everyone. I think I really echo with the thoughts of Dr. Soman in the last session. Being the last speaker really takes away all your talking points. And I also have the added pressure of being between you and lunch. So I think I'll skip a lot of the slides and share more about the work that we're doing at PATH and the practical experiences that we have learned over the past few years. Setting the context, I think it is well established that about 30 to 40% of the population in India is youth, and that gives us a huge opportunity for innovations, productivity, social and economic growth. And the way we nurture this population is going to be extremely important in the next few decades. We keep thinking about the SDGs 2030, but what beyond 2030? Are we really thinking in that direction? And especially when it comes to youth health. So I think we've already covered the kind of challenges that we face in youth health, especially in terms of morbidity. We've talked about mental health, sexual and reproductive health, substance abuse, digital addiction. We've talked extensively on poor nutrition. These are from the disease side of things. From the system side, we do have underrepresentation. We do not have enough funding for youth health. We have fragmented and siloed youth services across different sectors, targeting the youth, which includes health, education, and the social sector. Then, of course, there is limited access and affordability of adolescent-friendly health services. There is stigma and gender norms and socioeconomic disparities associated, which restrict their health-seeking behavior. And lastly, there is a digital divide. We cannot, overlook the fact that there is a digital divide. But over the past decade, if I may say so, there has been a change in the environment, and there is an enabling environment right now, which gives you the opportunity to build on digital health and AI. When I talk about the opportunities with digital health and AI and the enabling environment that we have right now, we have a internet penetration of 800 million people. 800 million plus people in India use internet, and there is widespread smartphone penetration. So we have the devices in place. We have one of the cheapest internet rates, which gives you better access. And it is, in terms of geographical spread also, it's quite widespread, the connectivity. Then when we talk about the national programs and the enabling ecosystem and policy framework, the Ayushman Bharat Digital Mission was launched in 2021, which provides the necessary digital public infrastructure for health, that on top of which different applications can work in a plug-and-play model and become interoperable with each other. We also have the India AI mission. We have different centers of excellence which are working on AI and health. That gives us a tremendous opportunity to advance in this field. Lastly, there is no dearth of technology. I think technology has not been a problem in recent times. We have enough technology, we have enough validated technology also now to be able to use. But the problem comes at the time of adoption. How do we increase adoption of digital health and technologies amongst the population? So some of the applications that we've talked about and the esteemed speakers also talked about, we have personalized nutrition applications, we have wearables, we have IoTs, but I want to talk more on the system side, how digital health is working on the service delivery side. And can I have some water, please? Yeah, so I'll share more on the system side, on the service delivery side, and some of the work that we are doing. When Ayushman Bharat Digital Mission was launched, it showed huge promise, but it was mostly adopted in the public sector, and private sector adoption rates were low. So we did a pilot in Mumbai, and we thought that single room clinic doctors should use an HMIS, should use digital technologies to generate electronic health records. How do we increase that adoption? So we piloted a model. We saw that doctors are willing to use digital technologies, but if it provides value proposition to them. ABDM spoke more on how you can access longitudinal health histories of patient. But when we spoke to doctors in smaller clinics, they said, patients come to us for cough and cold or flu. We don't want their health history as much. We would want a digital solution for appointment booking, for administrative purposes. That was their value proposition. So, we saw a lot of adoption there. And when we talked about doctors' experiences, they said that our younger patients are more, open to accepting electronic prescriptions. They would want access to their digital health records. That has been their experience. Another experience that I'd like to share is from our project in Maharashtra. We are implementing a comprehensive primary healthcare application. The issue with maintenance of health records with frontline workers was that they have 15 to 20 registers that they have to maintain regularly. Then the 15 registers were replaced by 15 applications. All of their time was spent on entering data, and time for actual service delivery was reduced. So what if we have a single interface for frontline workers wherein they enter data and the data is actually usable for them? And if you want that data to go into RCH portal, it can be pushed there. If you want that to go into NCD, it can be pushed there. So we are implementing this application with a district saturation approach in Maharashtra, and it has a lot of applications on the youth health on SRHR. I'll give you an example that an ASHA has to maintain the records of eligible couples and provide family planning services to them. Now, first she has a record of all the village. Then from that she manually filters out how many eligible couples are there. Then she has to manually, maintain a timeline. When do I go to this person? When do I go to that person? The application that we are implementing automatically serves as a job aid to the ASHA, and they are able to, filter out information, relevant information from the denominator that they have. So the time spent on maintaining registers, on maintaining records is lesser, and the time spent on actual service delivery is more. When we talk about implementation of digital health, it does not restrict to applications. You can build the best application in the world, but if you don't have the policy environment, if you don't have the necessary budgets, it will not be sustainable. So as part of our initiative in Maharashtra, we are not just focusing on implementing the application, but also looking at a state digital health roadmap coming up, so that the state knows that these are the kind of budgets I need for investing in digital health, for capacity building, for building centers of excellence. How do I consolidate budgets? Right now, the digital health budgets are fragmented across different programs, and there's duplication also. And I won't say that it's the most efficient use of resources. So the roadmap actually helps the state plan in such a way and have an implementation plan in place. Another observation from our work in Maharashtra is that we have this myth that frontline workers are not open to adopting technology. Actually, they are open to adopting technology, but again, the issue lies in value proposition. If you give them 10 applications and you have to enter the same data in every application, they will not use it. But if it makes their job easier, they will be more than willing to use it, and there are no age barriers associated with it. I also want to share that we had done some work in Satara district of Maharashtra, where we focused on point of care diagnostics. When we talk about implementation of diagnostics in a public health setting, again, you can have the best technology and most expensive technology in place, but how do you implement it in public health settings? How do you make it scalable? How do you make it sustainable? So that's another pilot that we tried with medtech technologies for breast cancer, for cervical cancer, for cardiovascular disease screening. Then we have, I think lastly, I want to share some work on rice fortification that we had done. We had extensively talked about nutrition. So India's fortified rice program was implemented with a huge ambition. But when it came to actual implementation, there was an observation that, suboptimal quality of rice was being taken in the service delivery, in the supply chain. So there was a need for traceability, quality control, and quality assurance in the rice fortification program. So we worked very closely with FSSAI and with the state government of Andhra Pradesh to develop this digital system for them. And the success of the platform was defined not by how much quality fortified rice was in the supply chain, but by how much quantity of fortified rice was rejected because of poor quality. That actually added value to the program. And now I'm very happy and proud to share that the fortified rice quality management system was scaled up across the country. It was also implemented in Sri Lanka for the school meal program, and is now certified as a digital public good, which can be used by other countries also. So I think the aim or the intent of digital health and AI is not to replace human care, but become an accelerator or an enabler for the care that we intend to give. And with that thought, I'd like to conclude the speech. Thank you so much.
Dr. Gupta, thank you for laying out Path's kind of diverse portfolio of work in this space. And I think my takeaway from your talk was the importance of not allowing the silos that we've had in programs and that we've grown up to just be repeated in technology, so that we need to break out of these silos and use these technological platforms to provide holistic care to individuals. And that even starts at the level of looking at budgets and breaking out open those budgets, which I thought was fascinating. We don't have a lot of time left, so let's dive straight into questions. Our first question has been submitted on paper, which I think is not embracing the theme of technology and artificial intelligence, but it's still very effective, so it works. This is from Dr. Parthy, and it's a question for Dr. Mona Duggal. Can ICMR include a list of preservatives and other food additives, including those used as fumigation or part of processing and packaging, to learn about the impact of endocrine disrupting chemicals on health? He further clarifies that these chemicals cause hormone imbalances that are of great concern for adolescents who obviously are going through puberty at the same time. So what can ICMR do to help us study these problems?
Who asked this question?
Dr. Parthy from the Institute of Biohospitals.
He's not there. Okay, so those questions are coming up even when I'm sitting on the panel, and it's probably one of the areas where we are looking actively to do research. Yes, so I think to Dr. Parthy, yes, as ICMR, we are a part of a lot of the committees I think you had seen at FSSAI. And as we are doing that cross collaboration, this is one of the areas we are now actively looking at. So to him, I think, yes, it's an important question and we will be doing the research. Yeah.
Thank you. Questions from the audience? Suman.
Hi, my question is for Dr. Arora. So you were mentioning about your engagement on the taxes. So if we look at, say, the reduction in the taxes across most of the food groups, so chocolates, ice cream, namkeen, and other food groups have actually seen a reduction in taxes from 18% to 5%. And the only food group that was, I think, singled out as being unhealthy was the sugar-sweetened beverages, which remained at close to 40%. Just wanted to get your thoughts on what was special about this group that it was deemed unhealthy and the others weren't, and what can we learn from like your experience there?
Very appropriate question. This has been definitely a concern for many of us who have been working in this area. Even this 40% on sugar sweetened beverage is not enough to hit the demand. So we had actually expected, and what the pundits say of taxation is even if we take it up to 60%, only then we will be able to hit demand. So our recommendation was actually another 20%. So even we have not made a dent there. And definitely the reductions currently in all the ultra processed food is definitely not on the public health guidelines, and will definitely not benefit health in any way, but yes, it will be benefiting many other manufacturers in that direction. So I would only say that, see, taxation is one strategy when we say that it will hit the demand. And another angle of taxation is that we raise these taxes on unhealthy food items so that we can subsidize the cost for fruits and vegetables and other healthy food items. So it's like we have to draw that balance, and it is a multi-pronged strategy. So just raising the taxes would not be enough. We have to do community mobilization. We have to do awareness, sensitization, why people should reduce sugar in their diet, why they should reduce salt intake. All of that also has to come in, because we all know that these ultra processed food items have been made so cheap, and their I think access is something we as public health professionals need to learn. A Lay's or the namkeen is available at the farthest possible marginalized population is able to access it, where healthcare has not reached. So there is much more to learn from these access points. So taxation, I would just say, is one very small segment of this multi-pronged approach that we need to adopt.
Hi. My name is Shweta Khandelwal, and I was blown away with the AI sort of information that we got from this panel. Kruti, my question is to you. When Arman has got this whole network with the ministry, and you've got such a good program, like in fact siloed approaches in some ways, but you're trying to converge them with the Tech Plus. There are several development partners who are also trying out several of these ways. Is there a way, or is there a collaborative approach in the interest of public health nutrition that you're thinking about? Because I think that would be very valuable. You would have from different states a lot of experiences which perhaps given your branding, given your scale, given your endorsement with the ministry, would work. So that is my first question. And the second is maybe a general question to all of the people. We have seen ethics in AI being there as an academic exercise or no, that's not the right word, but being recognized at least. But I'm not seeing that really translating into, even till now, we are being asked to accept this for adolescents, for any age group for that matter. But we really don't know how to deal with the ethics part very clearly in practical terms. So any guidance? Thank you. Stop.
Thank you. Thanks, Dr. Khandelwal. I'll take the first part, and maybe I'll let the others respond to the second part. Yeah, absolutely. We completely believe in a collaborative approach. All our research, all the work that we're doing with AI is with partners. We work with Google Research. We worked with IIT Mumbai for the study where we use the AI model for predictive analysis. We're working with Art Park for the chatbot. So definitely open and always looking for collaborators, both on the technical side, but also on implementation. Like I mentioned, there are so many existing networks already in the country, either government or of partner NGOs. So even on the ground in the harder hard to reach communities. We're working with peer organizations that already have a foothold in the community, who already have the CHVs on the ground. So very open to collaboration. Please do find me after this, and happy to discuss.
I'll take the ethics question because I think that is a big elephant in the room at this point, actually, with the new DPDP Act and the other things that are. So, just for the information, we have a new DPDP Act that is around the privacy that has just come out. And if it is especially for people who are doing research, and if any of the, there's a lot of concerns now. If any of the data that is deemed like very highly sensitive leaked, so the companies are actually like, they are going to be slapped with huge fines, except probably the research component, which I think ICMR had given a recommendation. Unless until it's deemed research, it is something that you will be exempted. Otherwise, there are huge fines that have been slapped. But again, coming to the ethics point, we still are doing it because generally what has been happened, it has been very clinical and academic based. But many of the states where a lot of this data, which server, how it is going to be, implied consent, what are this? These are things that are now we are discussing. So hopefully we will have the guidelines soon. I think we are already working on it. The data work groups have been formed, health work groups have been formed. So that is a part of our institute mandate itself, but something that we are looking at actively, because now it's something is population research and with the digital part that is separate, where data itself is being received by the states at a massive level, versus what is the clinical and the clinical trial approach. That is generally what the ethics has traditionally been meant in that system. Yeah.
If you can make the question very brief, and then we'll move.
Thank you. So my question is for Kruti for the chatbot that you have shown for Art Park. We understand that the messages that are being sent have a cost attached to it. And if they are sent through a server, then they come at a cost and they are different. So what is your financing model to support these chats? How do you do that?
Thanks for the question. So we have the chatbot element right now on the health worker side, but we're also looking to build it for pregnant women and mothers through Kilkari, which is the government-supported program. So the model, when we work with governments, it's a PPP model. So they pay for the telecom costs. So the WhatsApp cost also will be borne by them. That's something we are pushing for. Right now, it's in a nascent stage. So our approach is to pilot, to prove the effectiveness of that intervention, and then let the government take that on. So currently, because it's at a pilot stage and it's in 4 districts of UP, it's being financed by Arman through funders, through philanthropic support, but it will be taken on. The advocacy is for the government to take it on because we're working in partnership with the state government, and in the case of Kilkari with the MOHFW.
Yeah, thank you.
Thank you so much for those wonderful questions, and to our panel and chair for those insights on the complex issue of digital health and AI. I'm so sorry, we are running behind schedule, so if you could...
It's a very small question. A very small question to Dr. Mona Duggal. You have rightly said that real-time data is very necessary for policy makers, and I completely agree with you. You may be aware that we have integrated health information platform under which we have many modules. We have modules for IDSP, we have modules for HMIS, then we have module for various national health programs. It's a platform where the real-time data is basically entered on a real-time basis, and it is very useful for policy makers. So my question is, has ICMR taken any initiative for incorporation of a separate module for nutrition, wherein you can link your portion tracker or various surveys and other the data which is being collected at the ground level under Ministry of Health and Family Welfare?
I think Dr. Shweta was here. She's a part of some of the committees already there. But if you actually go to the ICMR site, we now have a data science website. You have a link to the data science thing. So we are now in that baby steps, because it is like, as a responsible organization, we have to be very sure what kind of data is being posted at that point. So those ideas, we are open to those ideas, how we integrate it. But we have already started, because I think things start to happen once there's a demand, and the demand is already there. We already have an AI course you might be aware of, which is with MIT. MIT is pressing us for the health data, and we are now reaching out to different data aggregators to kind of see how we can bring it to the common sets. But yes, we are open to ideas. As we said, the institute is very new. We already have the verticals, and one of the main thing is like, how do we get good quality, high quality data that is we can actually provide ethically, and that is what was said to many of the startups, and especially for validation, development, and monitoring and evaluation. So that is a huge thing that, yes, but we are open to ideas how we can actually work together. Thank you.
Thank you.
Thank you. All right, thank you, our panel. Let's give them a round of applause, please. Could I please ask Ms. Mira to come on stage for a group photo and felicitations?
Oh, did he say that? Oh, मेरे साइड में क्यों नहीं है? I want to hide behind here. All of you did a wonderful job. I just that we are piloting together
All right, and now some felicitations. We'd like to thank Dr. Mona Dugal. And thank you to Dr. Pierre Thomas.
So let me सबको दे देती हूँ खाना खाना है. So let me give it to Pierre.
Thank you to Dr. Professor Monica Aurora. And to Dr. Shobha Suri. And Miss Kruti Dalal. And Dr. Tanu Gupta. Thank you. All right, thank you so much, everyone.
Yeah, so they like to kill us always.
Wonderful. All right. Thank you. Thank you, everyone, for your patience. I can hear grumbling tummies from over here, so we will break for lunch. And we will return in about half an hour for our final technical session on governance, financing, and convergence. And this is the end of my time with you all, so thank you for being such a great audience, and have a great lunch.